Okay, well, it is 12 o'clock, so we're going to go ahead and get started. So thank you again to everyone for joining us. My name is Katrina Hernandez, and I am an engagement specialist with OPEN, the Overdose Prevention Engagement Network. Welcome to today's webinar, Co-occurring Psychiatric and Substance Use Disorder. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work CE, and McVAP credits for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar, and we will also email the continuing education credit information after the webinar today. As I mentioned, my name is Katrina Hernandez, and I am an engagement specialist with OPEN, and will be moderating the webinar today. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work with healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain and can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and McVAP credits. And for prescribers, all of our credits also qualify for the DEA required SUD training. We provide MOUD training for physicians, and this year we are incentivizing primary care physicians with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. You can access more information about all of these services more directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable education materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants. And we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. For overdose rescue support, we fund implementation of naloxone vending machine and distribution boxes and offer naloxone administration trainings. These trainings are offered as live, virtual, or free online training courses. No planners, faculty, or others in control of content, either individually or as a group, have relevant financial relationships with ineligible companies. Our presenter today, Elizabeth Liz Hoffman, MD, received her BA in psychology from Kenyon College and her MD from Loyola University in Chicago. She completed her residency in internal medicine and psychiatry at Duke University and subsequently joined the faculty at the University of Michigan in 2021. Dr. Hoffman is a board certified in internal medicine, psychiatry, and addiction medicine. She splits her clinical time between hospital medicine, psychiatry consults, and addiction consults at Michigan Medicine. So thank you, Dr. Hoffman, for being here, and I will turn it over to you.
Great. Good afternoon. Thank you so much for being here, and I appreciate the introduction, Katrina. Thank you. So today I'll be talking about co-occurring substance use and psychiatric disorders. So let's get into it. I have no relevant disclosures. So this is really a large topic, and I won't be covering details about all the combinations of substance use disorders and mental health disorders that you have already or are likely to encounter. Rather, I wanted to give you some background information as well as general strategies and tips for managing these co-occurring disorders utilizing a few common examples. So we know a great deal about substance use disorders and mental health disorders in general, and that individually they are quite common. Just to note that throughout the presentation, I use the terms mental health disorder and psychiatric disorder interchangeably. Per SAMHSA in 2023, 58.7 million American adults, accounting for about a quarter of the population, had any diagnosable mental illness, and approximately 15 million adults met criteria for serious mental illness. That same year, 48.5 million Americans over the age of 12 had a substance use disorder, most commonly alcohol use disorder. We know that the pandemic increased rates of both substance use disorders and mental health disorders and the demand for widely available treatment options. Where these disorders intersect is what we're talking about today. These terms are used interchangeably. However, there are some important differences. Co-occurring disorder refers to any two conditions or disorders that occur simultaneously. A comorbid disorder refers to two or more disorders interacting in such a way as to worsen the course and outcomes of both. And this term more accurately reflects the reality of the complex nature of this intersection. Dual diagnosis is a more outdated term, but you see it used frequently in the literature. So when we talk about co-occurring disorders, we are talking about any combination of a substance use disorder and mental health disorder. And we know that in reality, people are often dealing with more than two issues, sometimes in combination with medical disorders as well, so it can get pretty hairy. In 2022, about 1 in 12 or 21.5 million US adults had a co-occurring psychiatric and substance use disorder, and over a third of individuals did not receive any treatment for either mental health or substance use. Generally speaking, people are more likely to seek mental health treatment than substance use treatment. And also, the more severe the problem, the more likely someone is to get treatment. Often because the problem is more difficult to ignore, or more likely to be noted by others as it impacts someone's ability to function or navigate through life. This data is from 2017. It's a little bit of a busy slide, so I apologize for that. But I did find it interesting because it conveys the primary reasons as to why people did not receive care. I know many of you are correctly thinking here that access is a huge barrier. So for adults with co-occurring disorders who did not receive mental health treatment, over half could not afford the cost of care. And about a quarter of people didn't even know where to go. It is incredibly difficult to navigate the system without assistance. It has gotten easier to obtain care since the expansion of telehealth. However, it's complicated to know where to look in the first place. This is true for both psychotherapy and medication management. For example, the wait list to get into psychiatry at the University of Michigan is several months long, and there are insurance barriers to receiving care at University of Michigan's Outpatient Addiction Treatment Center. For adults with co-occurring disorders who did not receive substance use treatment, over 38% were not ready to stop using. I think this is probably consistent with many of our clinical experiences, and I think why it's important to always maintain an open door policy when it comes to providing treatment. Similarly, 35% of people did not have health insurance and couldn't afford the cost. And then stigma is also a major reason as to why people did not seek treatment. We know that having a co-occurring or comorbid disorder makes diagnosis and treatment more challenging and is also associated with higher rates of hospitalization and relapse, higher overall treatment costs, higher rates of incarceration, homelessness, as well as suicide attempts and completions. Having a mental health disorder increases the risk of substance use by about twofold. Individuals may use substances to manage psychiatric symptoms like insomnia, anxiety, depression, paranoia, or to alleviate the side effects of psychotropic medications like antidepressants or antipsychotics that cause fatigue or brain fog. Many people use because of stigma or because of wanting to fit in with their social environment or because it feels good. Especially as use becomes chronic, people are using to just feel normal and avoid the negative effects of withdrawal. Keeping these things in mind, I think, helps us as providers to have compassion for people, particularly when folks have trouble maintaining abstinence. We really want to meet people where they're at and encourage them to keep showing up for treatment, even if there are setbacks. I know many of us have seen this slide before, or this schematic before. For many people, initial use of a substance is typically impulsive. And if the experience creates a positive feeling or alleviates a negative feeling, well, then that reinforces use. The environment and social circumstances also play a role here. Over time, repeated use leads to tolerance. Often people will increase the amount or frequency in order to achieve similar results as the initial or early effects. But over time, the absence of the substance feels terrible due to a state of withdrawal created by the downregulation of neurotransmitters and their receptors. So there's an overall shift from use being impulsive to being compulsive. And really, this is the body's natural tendency towards homeostasis. Because substances hijack the brain's reward system and alter the dopamine, opioid, and other neurotransmitter pathways, these different stages can look very similar to and over time contribute to the development of different psychiatric disorders, particularly depression, but also anxiety, psychosis, mania. Trauma and PTSD, adverse childhood events, and chronic stress also create neurobiological changes that contribute to an individual's overall vulnerability to developing both mental health and substance use disorders. Making the diagnosis of a psychiatric disorder in the context of substance use is challenging, as symptoms of substance intoxication or withdrawal can look a lot like the active symptoms of a psychiatric illness. For example, psychosis and methamphetamine intoxication, or anxiety and alcohol withdrawal. Particularly in the emergency department or on inpatient wards, many of us are seeing patients and making an assessment based on a specific point in time without having an understanding of the whole picture. Patients might be impaired, which makes it challenging to obtain a history, or you may not have access to complete records or reliable collateral. And even if patients are able to provide a history, it might be incomplete because of lack of trust in the medical system or providers, fear of retribution, or confounded by prior trauma, cultural factors, and more. But throughout my training, which was within the past 10 years, it was considered standard of care to treat substance use disorders and mental health disorders sequentially. In other words, we did not fully address the patient's mood symptoms or anxiety until there was a period of abstinence from substances, which was typically several weeks to a month at least. This approach generally stems from a belief that one disorder causes the other, or if you treat one, then the other will resolve. And we know that things are just more complicated than that. Often these conditions exist independently and are informed by each other as opposed to one being solely responsible for the other. Treatment was determined more by severity of either illness and per patient preference. And to a large extent, this is still true today and may be appropriate, particularly if there are acute issues. But the disorders are treated separately in the sequential model. Often this is done by different service providers that don't communicate with one another. And this can result in treatment delays, increased risk of relapse of one or both disorders, and poor outcomes. I think today the parallel model is quite common in practice, where the disorders are treated simultaneously, but similar to the sequential model, by different entities that may not have adequate knowledge of what the other is doing. There is an overall push to integrate assessment and treatment in order to more fully conceptualize the individual from a biopsychosocial and holistic perspective. The aim really is to have a single collaborative treatment plan that takes into account all the complexities contributing to the comorbid disorders. We know that there's no one-size-fits-all solution to delivering quality care, but for both patients and providers across regions, both for patients and providers across regions and within different communities. But generally speaking, an integrated care approach aims to address these issues simultaneously and in communication with one another. The most important thing to recognize here is that the more integrated the services, the better the outcomes for quality of life, mental health, and recovery from substances. There are challenges to implementing integrated care. In the United States in 2014, only 18% of addiction programs and 9% of mental health programs offered integrated services. And to my knowledge, these numbers have not significantly changed over time. Some of the barriers include lack of appropriate guidance and trainings, lack of institutional support or central organization. These are some of the major components to a dual diagnosis inpatient unit. As an example, not only is there case management and psychiatry and addiction services to offer medication management, but also a range of psychotherapeutic interventions, as well as mutual aid groups. I think a necessary component here that is missing from this slide is community connections to ensure a safe and smooth transition to the outpatient setting. And a lot of that is created through relationship building. I want to point out contingency management that has excellent data for stimulant use disorder, as well as some data for cannabis use disorder. And I'll add here that DBT, or dialectical behavioral therapy, is a very effective behavioral therapy for patients with borderline personality disorder, many of whom have a history of trauma and interpersonal instability. And then CBT, or cognitive behavioral therapy, plus motivational interviewing, has some of the best outcomes for patients with co-occurring disorders. I want to call your attention to two qualitative measures used to assess capacity for dual diagnosis treatment, which can be applied to either existing addiction treatment or psychiatric treatment facilities. Okay, so I wanted to go through some case examples to break up some of the monotony of me talking and get you all engaged. So in this first case, Mr. A is a 47-year-old married electrician who was referred to clinic after his family, including his wife and 2 teenage kids, was concerns about his drinking. He's been drinking alcohol since his mid-20s. For years, he typically drank 3 to 5 beers a day, most days of the week. However, for the past 6 years, he has been drinking approximately 6 beers nightly during the week and up to a case on the weekends. He sometimes passes out on the couch and misses family gatherings, which upsets his family. He's continued to work and has not called out sick. He's had multiple periods of abstinence as a result of his family's concerns. His longest period of sustained abstinence was 5 months last year. As of the clinic visit, he has not had a drink in 4 days. Over the past several months, Mr. A has been feeling sadder and more irritable. He's been unable to sleep through the night and is fatigued during the day. He's been experiencing low appetite and is less interested in spending time with family and friends and sexual activity. He expresses guilt over his lack of interest, and he has experienced episodes similar to this lasting several weeks at a time in the past. He denies homicidal or suicidal thoughts. He's never seen a psychiatrist or been on psychiatric medication previously. A physical exam reveals no tachycardia, sweating, or tremor. He does have mild hypertension. So what is the most likely diagnosis? And I'll submit a poll for you all. Is it substance-induced mood disorder, major depressive disorder, or alcohol withdrawal? I think we'll just move on. And so keep in your head here, what you think the most likely diagnosis is. And then what would help to clarify the diagnosis? And you can kind of ignore the poll for right now. So A, determine if he has a history of complicated withdrawals, seizures, ICU stays, delirium tremens. B, ask his wife if he has ever had psychotic symptoms associated with his depression. Or C, determined if he experienced any significant depressive episodes during his prior periods of abstinence. The majority of folks said C. Good. So determine if he has experienced any significant depressive episodes during his prior periods of abstinence. So here is where the DSM is really helpful to sort through differential. So for a diagnosis of major depressive disorder, a patient needs to have at least 5 symptoms present during a 2-week period, one of which is depressed mood or anhedonia. Persistent depressive disorder describes a low-grade depressed mood most of the day for at least 2 years. Premenstrual disorder doesn't apply in this case, of course, but does refer to mood symptoms that impair functioning and occur about a week prior to the onset of menses, and then improve within a few days after the onset of menses. Substance-induced mood disorder occurs when symptoms are due to the direct physiologic effects of a substance and develop during or soon after intoxication or withdrawal. Substance-induced mood disorders typically resolve within several weeks without intervention outside of abstinence. So in our case, if the patient has episodes of depression during periods of abstinence, the most likely diagnosis is major depressive disorder comorbid with likely moderate alcohol. We know that individuals with alcohol use disorder are almost 4 times more likely to have co-occurring major depressive disorder. We also know that depression as a result of chronic use is common, which is in contrast to substance-induced anxiety disorders, which are quite rare. Any use of alcohol in adults increases the risk for suicidality, with higher blood alcohol concentrations corresponding to a higher acute risk for suicide. Approximately 20 to 40% of people with anxiety disorders have alcohol use disorder. This is more likely to be a primary anxiety disorder than a substance-induced anxiety disorder, like I mentioned. And social anxiety is an early risk factor for the development of AUD or alcohol use disorder. It's important to use a standard algorithm to treat major depressive disorder or generalized anxiety disorder, and use screening tools frequently to follow someone's trajectory. Medications for alcohol use disorders have been shown to be safe and effective for people with co-occurring disorders. As an aside, this also goes for patients with opioid use disorder on buprenorphine and methadone. There have been several studies and retrospective analyses showing an antidepressant effect associated with buprenorphine due to its antagonism at the kappa opioid receptor site. We do need to review our drug-drug interactions for our patients on methadone, given its P450 metabolism. I also want to mention that we really want to avoid use of long-standing or chronic benzodiazepines in individuals with anxiety, or any use of benzodiazepines in patients with PTSD, as it worsens outcomes. So while I'm on the topic of mood disorders, I do want to mention bipolar disorder. Bipolar 1 is characterized by manic episodes lasting at least 1 week, which are typically excessive and impaired functioning. Major depressive episodes are common in bipolar 1, but they're not required for the diagnosis. This is in contrast to bipolar 2 disorder, which is characterized by hypomanic episodes, which are less severe than full mania and do not typically necessitate hospitalization or cause significant functional issues. However, bipolar 2 does involve major depressive episodes. Substances, most often stimulants, can cause manic or psychotic symptoms and mimic primary psychiatric illnesses. It is not uncommon that I come across individuals with a bipolar diagnosis, and when I do a deep dive into their history, and this is also where collateral is helpful, my suspicion for bipolar disorder may be low. The key here is really to determine if the individual has ever had manic episodes outside the context of substance use. This is one of those diagnoses that once in the chart, unfortunately, really sticks with people and has a tendency to be accompanied by polypharmacy, most often multiple antidepressants and antipsychotics. The other thing I'll say here too is that this diagnosis is sometimes made in patients with a history of trauma who exhibit impulsivity, poor coping, poor distress tolerance. And that might be better explained by a diagnosis of PTSD or personality disorder. This misdiagnosis can also lead to ineffective polypharmacy. In patients with co-occurring bipolar disorder and substance use disorder, you will see improved outcomes with treatment of either. So here's our next case. Miss D is a 36-year-old single woman who presents to clinic requesting evaluation for ADHD, or attention deficit hyperactivity disorder. She reports lifelong problems with attention, impulsivity, task completion that started in elementary school, but states that she was never formally diagnosed with ADHD. She recently lost her job and for years has been unable to maintain steady employment due to difficulties concentrating and feeling easily overwhelmed. Miss D admits to daily methamphetamine use for the past 3 years. She typically smokes, however, has used IV in the past. She states that it allows her to function and helps her focus. She's tried to stop using multiple times, however, has been unable to due to symptoms of fatigue, depression, and brain fog. The chart notes several prior ER visits for anxiety and chest pain related to methamphetamine use. She smokes cannabis 2 to 3 times a week, but denies other substance use. She has no prior medical or psychiatric history and is not prescribed any medications. On exam, she appears frail, mildly pressured, and anxious. She fidgets frequently during the conversation. She denies suicidal and homicidal ideation and does not endorse hallucinations or delusions. She requests a prescription for stimulants for treatment of ADHD. What is the next best course of action? Okay, we've got about 60%. So this is really interesting. I'm going to share the results. Okay, so, answers are all over the map here. And this really just points to the fact that, this is a really controversial topic and a challenging topic. So there is data to support the use of stimulants in patients with stimulant use disorder and ADHD. ADHD is a clinical diagnosis. While neuropsych testing can be helpful to rule it out, it doesn't reliably rule it in and can be really difficult to access. Some considerations, if you do decide to trial stimulants, are to review any available data. So if you have access to collateral information or data from childhood, certainly if someone had inattention or hyperactivity prior to the age of 12, that raises our suspicions. But we know now that adult onset ADHD is a common diagnosis. So utilizing drug screens, checking maps, potentially trialing a delayed release formulation, ensuring frequent follow-up, those are all considerations. Remember that there are false positives associated with detection of amphetamines, and there are also several antidepressants that can cause false positives on a urine drug screen. So it's important to verify with confirmatory testing, which will show methamphetamine. Whatever your practice is, I do highly recommend that you're consistent in it and beware of bias, because there's many social inequities in prescribing patterns for patients with co-occurring non-prescribed stimulant use and ADHD. And we really want to be aware that stimulants tend to help everyone and not just people with ADHD. We also need to remember that symptoms of a psychiatric diagnosis do not reliably predict someone's drug of choice. Because this patient had a history of intravenous use, I do want to quickly touch on the importance of discussing harm reduction strategies in real time with patients. Provide information on how to access fentanyl test strips and naloxone. Consider buprenorphine if the patient has any history of unintended overdose. and ask and educate about the use of sterile needles, water, and cleaning techniques to reduce the risk of infections. All right, so this is our final case. This is Mr. P, who's a 22-year-old college student from out of state studying graphic design, who was brought to the emergency department by his roommates after several days of odd behavior. They report that Mr. P has been talking to himself in his room alone, yelling at the television inappropriately, accusing them of stealing his belongings and poisoning his food, and expressing paranoia that his professors are spying on him. He has barely slept in 2 days and refuses to eat. On interview, Mr. P endorses using daily marijuana for the past 3 years. He typically smokes high THC strains 2 to 3 times per day and occasionally uses cannabis concentrates or dabs. He denied using other substances, though he admitted to trying LSD and psilocybin mushrooms in the past year on a few occasions. He does have a family history of schizophrenia and his maternal uncle. On exam, he's unkempt, appears anxious with poor eye contact. His thought process is tangential and disorganized. Though guarded, he does endorse auditory hallucinations and throughout the conversation looks repeatedly towards the door. He denies command to auditory hallucinations, suicidal or homicidal thoughts. Basic labs, as well as a TSH, or thyroid, B12, RPR, which is a rapid plasma reagent, which is a syphilis screen, and HIV are all unremarkable or negative, and a drug screen is positive for cannabinoids. What is the next step in your recommended plan of care? You discharge home with follow-up in 1 week, refer to assertive community treatment, or admit to inpatient psychiatry or dual diagnosis treatment center if available. So the majority of people said admit to inpatient psychiatry or dual diagnosis treatments. And I would agree with C, particularly as he is not sleeping or eating without acute hospitalization. There's a high risk for further decompensation. So it's important to note, particularly in a state with legalized recreational cannabis, that it is associated with a 3-fold increase in the risk for developing schizophrenia. It's also highly comorbid with mood and disorders. As of now, 37 states have approved medical cannabis for the treatment of PTSD. Though the evidence is mixed, there has been some data showing that cannabis use is linked to double the likelihood of dropout from CBT or cognitive behavioral therapy and trauma-focused psychotherapy, both of which are integral approaches in the treatment of PTSD. There are no FDA-approved medications for the treatment of cannabis use disorder. I do want to point out here, in the case example, it's not entirely clear if the patient has schizophrenia or not. If the symptoms of psychosis are severe enough, we see this fairly often in methamphetamine-induced psychosis as well, it's very reasonable and appropriate to utilize antipsychotics to target delusions and hallucinations. You can always use a provisional diagnosis or substance-induced diagnosis while you're monitoring and potentially tapering off the medications. Remember that substance-induced psychiatric disorder will typically resolve on with abstinence, most commonly by the 1-month mark. However, symptoms may be so severe or persistent that we might need to reach for medications. In terms of general strategies for evaluation, we do want to avoid stigmatizing language. We want to start with the problem of greatest concern to the patient and have an open door or no wrong door policy. We need to not turn people away because they have another prominent underlying condition. It might take several evaluations to establish rapport and be able to make an accurate diagnosis. For example, repeated cycles of intoxication and withdrawal can also mimic depression. And this is where longitudinal assessment is really key. We do need, however, to take time to assess safety and suicidal and even homicidal risk at each visit and assess someone's risk for withdrawal as well. We want to frequently reference the DSM to help in our assessment and use standardized screening tools often. We also want to make sure that we're being patient-centered and not punitive, and have conversations with compassion about our medical decision-making and testing recommendations. We know that patients do better if they're involved in the agenda setting, goal setting, and treatment planning process. We need to use evidence-based treatments, but also be flexible, because recovery is not a straight line, and there may be many setbacks along the way. Okay, I just want to touch on a couple specific population issues and concerns. The majority of adolescents who use substances do not go on to develop substance use disorders. But when a mental health disorder goes undiagnosed or untreated, an adolescent will often attempt to self-medicate or self-treat with alcohol or drugs. Most common psychiatric disorders we see here include anxiety, depression, ADHD, PTSD, and we know these independently increase the risk of substance use disorders. As we saw previously, substances can also increase the risk of psychiatric disorders, as in the case of cannabis and schizophrenia. Sometimes it's difficult for adolescents to see the potential future harms associated with their use. So early education is really key, as is engaging family in treatment. Asking all older adults about their use of alcohol and other substances is accepted and expected in practice. People may require accommodations for hearing or vision impairment. Be aware that the DSM criteria may not apply to older adults who are retired or are more socially isolated. It's important to ask about episodes of confusion, their functional status, their risk or history of falls, and obtain collateral if it's available to you. Older adults might develop or are more prone to develop adverse effects despite no changes in their use of substances, because as adults age, their lean body mass decreases due to muscle wasting, as does total body water and volume. So the concentration of substances in the blood increases. This, along with normal physiologic changes of aging, may make a person more sensitive to substances. We want to make sure that we're educating patients about this early as well. And again, we want to make sure we're reaching for screening tools that have been validated in older populations and avoid public funds. Okay, so thank you very much. These are my references, and we have a good amount of time for questions.
Thank you, Dr. Hoffman, for that. We did have some questions that were in the chat. So someone asked, what was the answer to case number 2? I'm not sure which question they were referring to.
Let me go back. Okay. Yeah, there's not really a good answer, to be honest. I mean, I think it's what we know is that, you know, a short course of methylphenidate with follow-up in 1 week is a reasonable option. And there's more and more data coming out to show that, you know, you can use stimulants. It's also possible to trial a non-stimulant as well. I mean, there are a lot of options for that. There's several medications that I mean, nothing FDA approved, but several medications that can be used off-label. You could refer to a residential treatment for stimulant use disorder if it's severe enough, and the individual's functioning is impaired enough, or they're at acute risk of harm to themselves or others. And then referring for neuropsych testing, again, you know, I used to think that this was like the gold standard. It is not. Unfortunately, it will help rule it out, but it is a clinical diagnosis. And so it doesn't give you all the information, unfortunately. And it, you know, at Michigan, I know University of Michigan, it takes months to get in to neuropsych testing. So I think it depends on it depends on, I do think that, it depends on the patient's reliability, obviously, like I would also be tracking their stimulant, their non-prescribed stimulant use over time. And if they're, um, you know, if they're continuing to use despite the prescription of stimulants, then I probably would not do both. Not like buprenorphine and
Is the risk for onset of schizophrenia induced partially from cannabis different amongst age differences?
I don't know. I know that the you know young adults, I mean, your brain really isn't fully developed before the age of 25, really, and so the younger you are, the more vulnerable you are. So I, you know, I think generally speaking, children to early adults, I would say if the risk is high, and I would avoid it until, mid-20s, sort of my in general guideline.
Can you speak a bit about dual diagnosis in the context of intellectual disability populations? Also curious to know about any barriers to medical services, access to treatment in Michigan, and any study on best practice or evidence-based programs for integrated care models that are community-based. And I can read that second part if I can go back over that if it was a long question.
Well, is the second part also related to developmental disability?
I think so. It was all put together in one question. So I think the whole question is about intellectual disability populations.
That's a good question, and I I don't really have a good answer. I don't know the data specifically. I don't know. I'd have to look more into that particular.
And is it okay to use these statistics while attributing to the University of Michigan Medicine in a social media post?
I tend to avoid anything Michigan medicine and social media together unless it's sanctioned by the university. I mean, I think it's it depends on where the data comes from. If it's like published and is available online, then it's probably okay. But if it's editorializing the data, or, you know, I don't know.
And then we also
Okay.
had a couple comments. So the one was that answer certainly shows the discrepancy in admission to a psychiatric unit. If a person is not actively suicidal or homicidal, they will not be admitted into our local hospital. I've observed where a person who was actively suicidal was sent home.
Yeah, this is very state to state. There are a lot of differences state to state, and certainly even within the state of Michigan. I think it's challenging. Generally speaking, I think a lot of it has to do with capacity, and the ability to, take on patients. But, from a legal standpoint, I think, you as a provider, if you have concerns about somebody's, if a patient doesn't want to go into the hospital, but you still have a lot of concerns, and believe that they're an acute risk of harm to themselves or someone else, or just can't function, are so impaired that they can't attend to their basic needs, then those are criteria for involuntary commitment in the state of Michigan. Now, if I have had to make a case, a peer to peer, or have a one-to-one conversation with, an insurance company to say, look, hey, I think that this person really needs this. It's my professional opinion that they need inpatient service. If there's any pushback in terms of getting coverage. But typically I haven't had any issues with facilities in particular saying no. It's just
Okay, and the next comment, cannabis use disorder, I believe you stated there's no real treatment. Today, as a therapist, I have to look at cannabis now will most of the time have fentanyl in it.
say that last part again.
So as a therapist, I have to look at cannabis now will most of the time have fentanyl in it.
Cannabis is including fentanyl.
Yeah, that's what the comment was.
Oh, I mean, I have not seen that, but I wouldn't be surprised. So in that case, right, like if you're concerned, again, similar to the other case we talked about with the stimulants, even if a patient isn't necessarily intending to use fentanyl, but they, they accidentally overdose. I mean, that's where buprenorphine can be a point of conversation, and then also making sure that people have access to fentanyl test strips again. So if that is in the local supply, then yeah, that would terrify me. And I would really push on and lean on, distributing Narcan or having that available and fentanyl test strips so that people can test the supply and make sure it's not in there.
And how do you suggest that I approach working with probation officers who attempt to dictate SA treatment in terms of frequency or intensity? I must often refuse politely to work with them and focus on client care.
Can you repeat the first part of that?
Yeah. So how do you suggest that I approach working with probation officers who attempt to dictate, it says SA treatment in terms of frequency or intensity? I don't know if they mean SUD treatment.
Yeah, I don't know. I mean, I think that the sort of instinct to focus on patient care is the right one, as long as you're, if there are any particular legal, policies or procedures that you need to abide by, I would say clarify that, but otherwise, yeah, keep it patient-centered as much as possible.
And then this one is recommendations for a place in a Michigan location to direct a person who has been treated with buprenorphine for 9 years with no accountability for improvement with the treating physician and PCP who sees only yearly.
So my question is basically patient is being treated for the last 9 years, taking the higher dose of buprenorphine with no real accountability. Patient's able to kind of lie and get around being seen in person and is yet still being prescribed this medication. Patient is still not showering for weeks, at times months, staying in bed, just very dysfunctional. And family has actually had the patient go to, or had gone to court to get the patient seen. And because she went to our local emergency room, and the patient herself refused to be admitted for psychiatric evaluations, they let her go. So I'm just wondering if there's another step she's sort of like a lot of layers there. I'm just wondering if there is some place, a recommendation where you can kind of start from zero with really finding out what is going on. She's, I feel like she's just kind of off in no man's land.
Does she have an ACT team?
No,
No. Would she qualify?
she has a physician who does not accept insurance, who only is cash, who is the one who prescribes her medication.
Mhm. And she has a history of opioid use disorder?
Oh yeah,
Yeah. So it might be,
but
I mean,
she's
the benefits of continuing to prescribe that might outweigh the risk, right? If it's keeping her.
correct. However, she's not technically functioning. She's lost job. She can't hold a job. Again, not taking care of herself and not even getting out of bed for months. It's I don't know how to explain it.
And it sounds
Better
like
than
she
that.
was brought into the hospital and was evaluated by a psychiatrist and was deemed to not
Deemed to
require.
make her own choice and refused.
Yeah. Your hands are kind of tied.
That's kind of what, yeah, we've been stopped. So that's why I took this seminar, this meeting class, to see if there was anything else potentially out there.
Yeah, I mean, outside of, an assertive community team and having people go to her
Mhm.
to do some evaluation, maybe in the home, or,
Right.
You could, if a family member wanted to petition for guardianship, I mean, that is a possibility and can be, discussed in the court system.
Okay.
The judge can kind of decide if it warrants
Okay.
guardianship or not.
Okay.
And so that's another possibility.
Okay. Is there a place if the patient was willing to go for treatment that kind of does because she does have dual diagnoses. And it sounds like the PCP just kind of guesses at that mental health aspect, and the other doctor is strictly for the SUD. And of course, they don't communicate.
Yeah, I mean, that can be an offline conversation specifically to open about resources, if that's okay
Sure.
with you all, about potentially treatment facilities. It really just depends on where this person's located, their insurance.
Sure. Absolutely.
Good luck.
Thank you.
Okay, we are almost at time. I just want to mention that the information for the CEs are up on the screen. Again, this will also be emailed out to our attendees. If anyone has any questions, they can feel free to reach out to us with any questions on the CEs. I'm not sure if we can get one last question in. So the one is, with microdosing being used in other states for various mental health treatments, how do you feel this exasperates SUD?
Oh, like in terms of psychedelics in particular, maybe?
It doesn't specifically state.
Yeah, that's a tough one. I mean, I think I don't know all the data behind that. I think there's certainly several indications in the ongoing studies. But I do think that, it's helpful to have a good understanding of somebody's background and history and be monitored closely just in case there are any acute issues that arise. If there's any kind of worsening psychosis or depression or paranoia. So generally, I'm in favor of just doing that in conjunction or in, with a provider who can monitor. But it might raise risk of substance use disorder. Again, it probably depends on age group. and just vulnerability in general.
Okay, well, with that, we are at time. So thank you again so much, Dr. Hoffman, for your presentation today. I hope
Thank you.
everyone has a wonderful afternoon, and thank you again for joining us.